First thing to all the doctor colleagues out there, to Jeff's point, don't ignore floaters. Give a patient a chance to neuroadapt. So as you guys both said so eloquently, patients' brains can adapt to it. They can figure it out. So if a patient doesn't have a symptom at all, leave them alone. That's fine. I respect that. But you cannot judge the impact of a floater on a patient's quality of life just by how it looks. So I'll give you an example. I had a patient come in, and I was like questioning the patient. Honestly, I was like, really? It was like a small little dot floater. I was like, are you seriously really bothered by that? And I was like being kind of cocky about it. And the patient looked at me and he goes, and he put his finger in my face and said, Doc, you can still see the chart, can't you? I'm like, yeah. He goes, yeah, you're 20/20 still, right? Yeah. He goes, do you want to live with that in your face all day long? I was like, oh, wow. It's like a slap in my face, but it really made me realize I wouldn't want that in my face all day long. I don't care if I can still see great. So for me, I learned early on in my career that we as providers can't judge a patient and the impact of that photo on that patient just by the size or the shape of it.
Today's episode is supported by MacuHealth, a company trusted by doctors worldwide for their science-backed eye health supplements. Their formula, Vitreous Health, is specifically designed to support the vitreous, the clear gel inside of the eye, and help reduce the appearance of eye floaters. I'll talk more about this later in the episode, but first, let's dive into what causes eye floaters in the first place and when they can be a sign of something more serious. Hey, eyes and shine there, my friends. Dr. Joseph Allen here, and welcome to the Dr. Eye Health podcast, where we explore how to preserve, protect, and optimize your vision and overall well-being. Today, we're going to be talking about something that almost everyone experiences at some point, which are eye floaters. Those little specks, strands, and cobwebs that you'll see drifting back and forth in your vision. Most of the time, they can be just something harmless, but sometimes they can also be a sign of something way more serious going on, such as a retinal tear or detachment. And knowing the difference can save your sight. We'll dive into what causes eye floaters, when they're an emergency, and we'll explore the world of eye floaters treatments, including that of laser vitreolysis and other surgical procedures that are designed to remove them safely. Joining me are two incredible eye doctors from the eye centers of Racine and Kenosha. Dr. Jeff Banas, who is an optometrist who specializes in ocular disease and patient care, and Dr. Paul Singh, an ophthalmologist and researcher who has pioneered new procedures and protocols for laser-based eye floater removal. Together, we'll explore how these eye floaters form, the various treatment options that are available, and how new technology is changing what is possible for patients everywhere. So, sit back, relax, and let's take a closer look at eye floaters. When I was in my 20s, one of the first times I experienced seeing these little spots in my vision, right? I'd step outside, maybe it's a cloudy day, I look up and look around and I'm like, I see these little dark spots or kind of looks like cobwebs or hairs drifting around back and forth in my vision. And, I was in my 20s, I didn't know what exactly they were, but somebody, I think maybe my parents told me, oh, those are eye floaters or something. And I imagine a lot of our patients come in and they kind of have a similar experience. But I'm curious in your guys' words, Jeff, Paul, how do you explain eye floaters to your patients?
Do you want Jeff, I'll let you go first.
Okay.
I'll let you go first, bud.
Yeah, for me, to me, it's about building that relationship with my patients. So I'll share a story very similar to what you experienced, Joey. Is I'm very nearsighted myself. So for those industry people here, that means I don't see well far away, and that predisposes me more to developing floaters over time. I'm closer to a -12. So I've developed floaters at a young age, and same concept. I'm like, what is this? And I was in school at the time, so I rushed urgently to the urgent care. It was like, I looked it up on Google. I think I'm having a retinal detachment, and I will often relate that story to patients when they come in and they're explaining something similar to that. I'll go, look, at the end of the day, it's just a breakdown of the gel on the inside of your your eye, and it forms these little clumps on the inside of the eye that when light enters your eye, it hits those opacities and casts a shadow on your retina, which is the visual tissue that's responsible for everything that you see. And what you're actually seeing is the floater or the shadow of that floater. So that's how I typically just present it to the patient, that it's a very normal thing. It doesn't immediately mean an emergency, even though I, can empathize that I had the same kind of, experience. But for the most part, it's a normal age-related process. It can be sometimes related with things or associated with things such as trauma or emergency conditions. And I'm glad you came in, because we want to take a look at that to make sure that that's, not going on. But for the most part, by and large, a normal age-related process.
Yeah, I mean, that's a great way to explain it. And I think I do the same thing as you both, but I think what I would just like to add is, what you mentioned too, is that it's not just one dot or one clump. It can be many sizes, many shapes, many densities. I think that's the tricky thing about floaters. I think historically, a lot of us have talked about floaters, or patients have kind of perceived floaters as a dot or a little string. I'll say, hey, you have floaters. Like, no, I don't have floaters. Those dots I don't have. I have something different. I'm like, no, actually, any clumping of the jelly will cause a shadow, to Jeff's point as well. I think it's really important, because floaters can take so many different sizes and shapes, and they can manifest in different ways. So for some people, it can be a dark spot if it's closer, if it's denser and closer to the retina. That can make it appear more dense and more dark, like a spot. But it can be also like diffuse, where the clumping of the gel may not be as dense. So it can form a cloud-like. So people would say, yeah, doc, I have this kind of cloudy vision that kind of sways or comes and goes in and out of my vision. So that's what I've learned, is to understand kind of what the patients are kind of concerned about, and then be able to kind of correlate that to what we see when we look in the back of the eye. Because floaters itself is kind of a misnomer, because really the term that I like to use now is something called CSVO, clinically significant vitreous opacity. So for everybody out there who's not an eye doctor in any way, the eye is like a water balloon, right? So the back of the eye is kind of thick with a jelly-like substance, as Jeff was mentioning, called the vitreous. That gel is very thick when we're born, made up of kind of fibers and water. And collagen basically over time can break down, just like our skin breaks down and everything else in our body breaks down. All collagen in our body breaks down. As the collagen breaks down, it kind of clumps together. It pushes the water out. So you get this like lacunae of water and this clump of gel of the vitreous of collagen kind of floating around. And how dense they are, how big, how clumped together they become, can dictate what they look like to you as a patient. So again, they can be denser, they can be strong, they can be more diffuse, they can be strings and clouds. And that's kind of the tricky thing about floaters. It's kind of a misnomer in some ways, because we always think of that one dot as a floater. But to your point, guys, it could be any size and shape.
I know you have both kind of mentioned that these floaters are certainly age related, right? It's collagen, just like the collagen in our skin. As we get older, it starts to change. We get wrinkles, it sags. And so the collagen in the eye changes too. But I know I've had a lot of people who are young. I've had people ask me like, hey, I'm in my teenage years and I'm getting floaters. Should I be concerned, right? And I know, Jeff, you mentioned that you have a high level of nearsightedness, right? Being a high myope. And you mentioned even trauma, maybe. Can you guys speak to those kind of like non-age related developments?
Yeah, well, certainly the biggest concern that we have with a patient presenting with an acute onset or a new onset of floaters would be something like a retinal tear or a detachment. If a patient, and that can happen to anybody really at any time for any reason, but a trauma to the eye, unfortunately, sports, a lot of kids play sports, they get hit in the eye, say a baseball, something like that, cause a rupture or a tear in the retina. That can cause shearing forces in the retina and a specific layer of the retina that can then, throw pigment into the vitreous, for instance, that patients can see as floaters. Blood, if you get a break in any of the blood vessels or the tissue itself, you can get floaters formed from that. And even patients that are diabetic, whether that be a type 1 or type 2 diabetic, depending on how well they're controlled and how long they've been diabetic, they can have, unfortunate situations like a vitreous hemorrhage that can then lead to large floaters, or even a shower of floaters present in their vision suddenly. So it's not always age related, and that's why we do want to check it. But certainly, yeah, there are acute things that can occur with that too. Anything I missed there, Paul?
I mean, I think just inflammation. There are some
Yeah.
inflammatory conditions where people get, there's something called uveitis, even things like MS and other conditions can cause floaters to occur. So as to your point, I think the most important thing is if you see any new type of floaters that are not kind of consistent with what you're used to, any new change in your floaters, always go see an eye doctor just to make sure, because that's what, just to your point, Jeff, we want to make sure we rule out any other causes. And if it is from just quote unquote age related, and aging, to your point, John, it could be anything. It can be, you could be 40 years old and have a typical age related change, just like gray hair can happen when you're 30 or you're 80. It just depends. But yes, just want to rule out any other medical cause.
I know a big thing, and I've talked about this on some videos on the YouTube channel, but there certainly are small floaters. I think a lot of people will recognize them first when they're younger, maybe just tiny little ones, or just like translucent hair or wisps. But once people are getting closer into their 50s and above, then there's sometimes this large, sudden, abrupt floater that they start seeing, right? A posterior vitreous detachment is what I'm referring to. Can you guys kind of go ahead and explain a little bit more of what's happening and how that's why we often see like somebody in an older age kind of coming in, middle age and above are usually the people who are coming in, oh my gosh, I'm seeing this huge thing. Can you explain that a little bit better?
Yeah, so really with age, there's this depolymerization of the hyaluronic acid that causes the molecules to release their water and essentially cause the vitreous in a nutshell to collapse in on itself. And it pulls away from the back of the eye, and this is a normal age-related process that ultimately results in the vitreous is firmly attached to the retina in certain areas, one of those areas being the optic nerve. And when it pulls away from around the optic nerve, it creates a nice little round ring-like floater that we call a Weiss ring. It can sometimes collapse in on itself and look more like a half moon-like appearance. So we'll see patients report flashes of light from the stimulation of that vitreous kind of tugging on the retina as it's pulling away. They'll see an increase in floaters potentially, depending on how that vitreous has shifted in their line of sight. And then they'll often report that larger Weiss ring or half moon-like appearance because that detachment of the vitreous from around the optic nerve is kind of migrated forward there. So very common to see, especially in those patients in that age range as well. Yeah.
Yeah, and what's nice about a Weiss ring, I say nice, but it's clear for patients to describe it. A lot of times patients will come in and it's really hard for them to describe the string-like dots here and there. Like, I can't really tell where it comes from. But when it's a Weiss ring as a clinician, when a patient comes and says, "Doc, right there," it's always right there. It comes in and it comes right back out. And whenever time I hear that history of like, it just happens suddenly, it's like a clump, like a circle or a half moon, as Jeff mentioned. And so to my right of my vision, my right eye, or left of my vision, my left eye, 'cause that's where the optic nerve kind of is in the retina. And when you see that very distinct ring or circle that kind of comes in out of their vision, for us, it's kind of clear we kind of clearly know usually what that is all about. And it helps us because those are really very amenable to a treatment called vitreolysis we'll talk about, I'm sure, as well. So when I hear that history and I see that Weiss ring, for me, I get excited because I know I can take care of that patient and really usually do a good job to take care of those symptoms for them.
I know we've mentioned the risk of retinal holes, tears, and retinal detachments, right? And so I usually am always trying to repeat myself saying, like, if you see new large floaters, like new ones, any flashes of light, which you mentioned, Jeff, right? Because as the gel starts to pull away from the retina, it can create a tractional force that the eye doesn't know what to make sense of, right? That's as far as I know. And then the brain just perceives that as a flash of light. And I've never experienced that flash of light myself. I think maybe a few months ago I might have, but I've heard some patients describe it as like a camera flash or like a bolt of lightning. Have you guys heard patients say something similar?
Yeah, and the key giveaway for me too is often they report it in an arc-like fashion because of the curvature of the eye and the retina itself. So as that vitreous is pulling away and you're getting that tug and that tractional force, you'll see a flash of light that's often in an arc. So I'll hear a lightning bolt or like a camera went off on the inside of my eye in terms of brightness, but I'm looking for that arc description as well.
Yeah, another key sign that differentiate, let's say, a retinal tear or retinal detachment, which is when the retina comes off the back lining of the eye. So to your point, right, the vitreous is attached. If here's a retina, here's a jelly. As a jelly comes off, it kind of pulls a little bit as it's coming off. And that will happen transiently, meaning you may have a flash of light for a couple seconds, then it goes away and you're done. Doesn't really come back as often. If you have a tear where the gels come off, the retina's come off the back of the eye, and it's kind of flapping around because the retina's torn, then you get this consistent flash flash. It doesn't stop. Like a lightning storm. But like, yeah, it's not really going away. So if I have a patient that says, yeah, it happened a couple of times, I had a flash or two, and then I had new floaters, and then it kind of stopped flashing, that's usually a good sign. It's most likely a vitreous detachment. If they're like, yeah, no, it keeps flashing, it's not stopping, and that's happening more kind of constantly, that's a sign that really want to come in for sure, because you definitely think that could be a risk more likely of a tear or detachment.
Right. So if you have a patient that comes in and, they're seeing these new floaters, maybe they've seen a flash, and, and when they come in the clinic, we dilate them. We do full 360. We're looking everywhere. Sometimes they'll even pull out a Ganio 3 mirror just because I get a good view that way. You're a fan of that procedure. For our viewers and listeners who don't know what that is, it's a specialized contact lens that we put on the eye, and it gives the doctor a really pristine view. It's a little bit more technical, but it helps us view really far out in the retina. But let's say a patient comes in and you look at them and the retina is like, hey, good news, you've developed this PVD, there's posterior vitreous detachment, this large floater separated, but there's no holes, no tears right now. But what if they continue to see flashes a week later? Do you encourage them, okay, if you see a new flash, come back in, maybe something's changed? What do you guys recommend?
Yeah, so for me, posterior vitreous detachment is a dynamic process. It doesn't necessarily just happen immediately and it's resolved. It's something we have to monitor frequently because we're constantly looking for something like that, like a retinal hole or tear that maybe didn't develop initially, but could potentially have a chance of developing over time. So, I'm also looking for something known as Schaeffer's sign, which is pigmented cells floating around in the vitreous. I kind of alluded to that earlier. That would be an indication that there's a high probability that there's a retinal tear attachment. Don't quote me on the exact statistics, but I think it's like a 70% chance of, a patient having a tear back there, or significantly higher than if you didn't see that with no other signs. So, I'm really looking not only at the retina, but I'm looking at the vitreous itself, the vitreous body, to see what I'm seeing there. And if everything is clean and clear and I'm comfortable, and I feel like everything is fine, then I will often bring the patient back within a month and have them, see what's going on, but certainly alert me if you are noticing any changes that, would indicate a retinal detachment, and we, educate the patient on that. So increase in flashes of light, blacking out of your vision, like a curtain or veil coming over your vision, that's not getting better, distortion. One of the things I like to tell the patients to do, look at a wall, look at, or your door, for instance, and look at that edge of the door. If it's wavy, or not perfectly straight like it should be, that's an indication that something's going on in the retina, and we need to address that right away. But if everything looks, nice and sound and calm, and for the most part, a pretty routine posterior vitreous detachment, I will often have the patient come back in a month. Now, if I do see signs of a potential tear, I will look for that. I will ideally find that if I'm doing my job well, and I'll get them immediately over to our retinal specialist colleagues to get that addressed right away. If I see something that's not indicating a hole or a tear, but I still am concerned, like the increased risk for flashes of light, then sometimes I'll bring them back sooner. I'll bring them back in a week, and I'll say, let's just recheck, let's double check, put some ease of mind to the whole situation. And if I go 0 for 2 in terms of finding a retinal tear or detachment and no other signs or symptoms that it would be there, I give myself a pat on the back. I go, I've been very thorough. I haven't seen anything, and my patient is doing well. And then I'll still follow them up at that 1 month period and go from there, depending on how they're doing. What do you think, Paul?
I think you guys are great. I think the only thing I would add maybe would just be, or at the bottom line is, any change in the severity or symptoms. So in other words, if a patient says, yeah, no, the flashes are like, they're coming back again, but they're the same as they were, a week ago, and I didn't see a Schaeffer sign, and I had a good exam already, and I feel pretty confident, I'll probably say, just, okay, hang in there, let me know if it changes. And basically, I'm looking for severity, meaning is it more intense, more frequent, and any new changes in the type of floaters. If you see like a shower of floaters all of a sudden, if you say, yeah, doc, I had a couple new floaters before, but now all of a sudden I have more flashes of light, more intense, and I have more floaters all of a sudden too, that's a sign, come in like right away again. Because to Jeff's point, the jelly, the vitreous coming off of the retina, that vitreous attachment, is not happening the same amount at 360 degrees. It may happen partly here, and then it may change over here. And so it's kind of evolving. We call it evolving PVD. And so that's why the flashes may last longer. They come and go for a week or 2 weeks, 3 weeks, 4 weeks, but it shouldn't change in severity and or in the type of floaters. So any change from what they're used to, I tell them to come in right away.
Love that. So the one kind of other question about, because we've talked about retinal detachments, holes and tears. One other thing I've read in the literature, and I think I've only had one specialist kind of argue against it based on their opinion, but what are your thoughts on epiretinal membrane or macular pucker, if anyone's heard that term before, and the formation related to vitreous traction?
Yeah, I mean, vitreous traction, if you had so when you have a retinal tear potentially, a retinal hole, or even a retinal detachment historically, et cetera, or inflammation in the eye, you can kind of create an extra layer of cells. We call them epithelial cells and other glial cells and other cells that can kind of, long story short, cells on the surface of your retina that can actually grow, and they can grow and kind of form an extra layer on top of your retina. And they can kind of sometimes just sit there, and they're not a disease like let's say it's not like a progressive condition like a macular degeneration or something like that, but they can distort the contour, the natural smoothness of the retina, and they can kind of pull and tug and cause distortions of the receptors. So sometimes, to Jeff's point, if you see a straight line becoming wavy or something in the center, in the macula, which is the center of the back of the eye, where we have the most concentration of our receptors, if we start to see that membrane form there, that can cause distortion of your cells. And I think so any break or tear or disruption to the retina in any way can cause a proliferation and excitement of those surface cells that can grow over. So I think it's a risk factor, more likely when you have a tear more than a PVD, but that can happen. Absolutely.
Now, before we get into the surgical options for eye floater removal, I do want to take a quick moment to talk about our sponsor, MacuHealth. Now, many eye surgical procedures are amazing and can help a lot of people, but I know as soon as somebody says eye surgery, people can feel intimidated or overwhelmed by it. And many times when you see an eye doctor for eye floaters, chances are they've said, well, let's just watch and see, or they want to observe for several months. And that is where Vitreous Health comes in. Vitreous Health is an eye supplement that is based on peer-reviewed clinical research that shows measurable improvement in both visual disturbances as well as vitreous opacity areas. It works by addressing oxidative stress and glycation, the same exact processes that cause collagen clumping to form within the vitreous in the first place. If you've been told to just kind of wait and see, or you want to be more proactive about your eye health, then ask your provider if Vitreous Health is right for you, or check out macuhealth.com for more info. And if you want to save 20% off your first order, you can use our code ALLEN20 to save that 20% off. That is ALLEN20 and save that 20% off your first order at macuhealth.com. Otherwise, again, huge shout out and thank you to MacuHealth for supporting us, and let's get back into the episode. So the big question I know everybody wants to know is how to get rid of eye floaters. How do you treat eye floaters? And there's several different things, in the classic textbooks, basically it would say, just get used to it, give it time. But in the last, several years, there's been some developments, and there's now some really more solidified bona fide treatments. And again, that's why I want to have you guys on, because you guys are pioneering and doing those treatments. So let's just kind of break it down one by one from, let's talk about neural adaptation and how a lot of people just kind of get used to it. And then we'll kind of expand and go into deeper things. What as far as like the neural adaptation and just getting used to the floaters, what are your guys' thoughts with patients?
Well, I think, for me, that, and like you mentioned, Joe, I mean, that's the conventional training that we all go under, in the whole side when we give our oath in medicine to do no harm. So the first thing I'm looking at is, by and large, most patients will likely neuroadapt to floaters, especially if there's not a lot of them, anywhere between 3 to 6 months. Whether you talk to Dr. Singh or you talk to our vitreoretinal colleagues, I mean, that's the first thing we want to see, assuming the eye is healthy and that there's nothing else going on. Can the patient neuroadapt to the eye or to the floaters? Because if they can, then no harm, no foul, and everybody's happy, and we don't have to do anything that it creates a risk, even if it's a small risk of any kind. So, I'll tell the patients, oftentimes they'll be coming into me as a first line of defense in our office, and they'll be telling me all about their floaters, unless the patient was referred to Dr. Singh or our colleague, Dr. Sanka, who's also doing these procedures. They'll come directly to them for the floater treatments. But if they come to me and they're complaining about floaters and they are visually significant, the first thing that I'm doing is to determining how visually significant. And there's a number of ways that we can assess that with technology that we have in office. I'll let Paul elaborate on that because he's much more eloquent about it than I am. But essentially, there's ways that we can actually objectively quantify how impactful these floaters are. And we didn't have that before. And there's a lot of technologies or a lot of practices that don't necessarily have that technology. So for us, we are I'm blessed to be a part of the practice that can do that. So I will kind of start to take those measurements and I will monitor that as I'm seeing how the patient neuroadapts. And that was kind of how we were trained in school. If the patient can neuroadapt and they don't hurt anything, move on. They're not really causing any problems and there's nothing else you can do. But, being fortunate enough to work with Dr. Singh, who has championed this, and we lovingly call him the Floater King, he enlightened me that there are a number of things that we can actually do nowadays, procedural-wise, not only in terms of what we're doing in office, but what our vitreoretinal colleagues can do too, that I don't think was made clear to me as a student, just, how willing they might be, depending on the surgeon, to still actually go in and do something like a vitrectomy, for instance, which is another option. But in my mind, there's really four options. There's neuroadaptation, which is what we just kind of talked about, seeing if the patient can just kind of let it disappear and fade out of their vision. There's a vitrectomy, which is where we actually go in and we remove, pretty much 99% of the vitreous and replace that with air or a saline solution, sometimes even oil. There's the Vitreolysis procedure that Dr. Singh has championed, and he'll talk more about that as well. And then Paul, the one-step LVR procedure that we have pioneered in the office as well too, Dr. Singh specifically, that is now a fantastic option in terms of what I've seen for patients and their results post-operatively. So I've got a lot of options for you now. It's a great thing, it's a great field to be in because, Dr. Singh, if he taught me anything, and he's taught me a lot, it's that those floaters are visually significant and that we shouldn't ignore them, and we were kind of trained to just, again, leave them alone. But it's great to have options because if there's something I get complaints a lot, it's not just blurry vision that you would think, patients would come in for. A lot of times my routine eye exams are, and I'll ask my patient, how's your vision doing? It's doing great, but I got this floater that's just irritating me, and it's that, and overall they're healthy. So it's awesome now to have a number of options in our repertoire that can actually treat these floaters.
Yeah, that's a great summary, Jeff. And one thing I would add from a treatment option is low dose atropine was another way. If you're a clinician, I'm gonna talk to the clinicians out there for a second, but if you're a clinician, you're an eye doctor, and you see a patient that you dilate their eye to check for retina safety, and then the patient goes, "Hey doc, since you dilated me, I don't see the floater anymore." So what we do know is when you dilate the eye, you're able to neuroadapt better. You can basically ignore that floater. And so one of the treatment options for some people, especially overseas in Europe, has been very low dose, something called atropine, which is a long acting dilating drop. And so that's another option and I've used a few times here and there if I don't feel comfortable doing any one of the surgeries that Dr. Banas talked about as well. But yeah, I think that's a great summary. And if you don't mind, I'm going to just talk to both my colleagues and then I'm going to talk to patients because I think I have two messages I'd love to share.
Please, let's get all nerdy about it.
I'm going to get really geeky, but this is such a passion project for me and it's something I've lived now for the last decade and a half, and I just feel so strongly about it. First thing to all the doctor colleagues out there, to Jeff's point, don't ignore floaters. Give a patient a chance to neuroadapt. So as you guys both said so eloquently, patients' brains can adapt to it. They can figure it out. They can deal with it. And so if a patient comes with the floater, and whether it's one clump or multiple strings and clouds everywhere, I've been shocked as an eye doctor saying, I see a patient, I'm like, there's no way this patient's not having symptoms. I mean, they have to have symptoms. There's floaters everywhere. And that, something called asteroid hyalinosis, which is calcium salts. You think, how could they not notice that? And yet they're like, I don't have problems. So if the patient doesn't have a symptom at all, leave them alone. That's fine. And I respect that. But you cannot judge the impact of a floater on a patient's quality of life just by how it looks. So I'll give you an example. So after I did my first 15 lasers for floaters, we'll talk, I'm sure, more detail about that in a second. But I had a patient come in. And I was questioning the patient. Honestly, I was like, really? It was a small little dot floater. And I was like, are you seriously really bothered by that? And I was kind of being kind of cocky about it. And the patient looked at me and he goes, and he put his finger in my face and said, Doc, you can still see the chart, can't you? I'm like, yeah. He goes, yeah, you're 20/20 still, right? Yeah. He goes, do you want to live with that in your face all day long? I was like, oh, wow. I mean, it's like a slap in my face, but it really made me
Powerful.
realize I wouldn't want that in my face all day long. I don't care if I can still see great. So for me, I learned early on in my career that we as providers can't judge a patient and the impact of that floater on that patient just by the size or the shape of it. So that's one thing I would say to doctors. Number two is think about those doctors who treat cataracts now. I'm old now. I've been around for 20 plus years, trust me. And when 20 years ago, we were not taking cataracts out where we are now. Right? Because of the technology has improved, our surgery skills have improved, our measurements are improved, so many things have improved in the technology part of it that we now are offering cataract surgery much earlier. Of course, when they have symptoms still, but we're not waiting until they're so distraught. Then fine, now you're bad enough to have a cataract. If they're having symptoms and there's certain vision a certain way, we say, yeah, let's not wait because the earlier you take out, the better. Because technology has gotten better. Now that we have technology, we'll talk about the lasers we use and the illumination and the visualization that we have has gotten better, and we have treatment options. Now there's no reason to leave these patients suffering just because historically we did that. So we have to understand as times change, as technology changes, our perception and our perspective has to change as well. So I think that's the paradigm shift is for me as well. And for patients as well, it's one of those situations where when you go see a doctor, even if you've been told nothing can be done, just like anything else, things change. Ask your doctor. And if they themselves do not do it, that's okay. Not everybody has to feel comfortable doing the procedure, but ask, is there anybody else who can do it in the area? Because it's in your certain area now, there's more and more doctors that are doing these procedures to help patients who have floaters as well. And you're seeing it more accepted in both the retina community as well as the comprehensive, the non-retina doctors doing it as well. So those are two just basic messages I wanted to get out there to both the doctors and the patients.
No, I love that. Thank you for touching on that, and certainly your passion for it, because it just clicked to me. I remember when I was a kid, and growing up, we had one of those big tube TVs, from the 80s and the wood paneling. And I guess as a young kid, I threw a juice cup at the TV, and it chipped and caused a black chip in the kind of off center of the screen. And then for growing up, I had to watch TV with this chip, this part of it missing. And so that's why I blamed as a kid. I grew up in Minnesota. I probably should have loved hockey, but I couldn't stand it because anytime I tried to watch it on TV, I'm looking for where the puck is, and I always am just staring at that spot the whole time. I'm like,
That's
wow,
awesome.
the puck is up in the stands now. So
that's a great analogy, though. That's a great analogy.
Yeah. But I suddenly am like connecting. Oh yeah, that would drive me nuts. So let's talk about the YAG vitreolysis, because that's your child, right?
Yeah.
Tell us kind of the early days, like how did this start and how was it refined and improved over the years?
Yeah, no, that's a great question. So back in 2012, so I'm already dating myself. Back in 2012, we needed a new laser. So the YAG laser is a type of laser for all those out there that we use for a lot of different type of procedures in the eye. So after cataract surgery, there's a cloudy membrane that can form. We can do a beam of light, this YAG laser, to break apart that cloudy membrane to help you see better. It's called a secondary cataract. You may have heard of that before, or a PCO. It's also for people with a certain type of glaucoma, what we call a narrow angle glaucoma. We can make a small microscopic opening in the color part of the eye to deepen the eye to prevent you from having a certain type of glaucoma. Well, that same laser we can use to do this laser vitreolysis. So laser to break and vaporize the vitreous opacity of the floater. Now, when I was in 2012, my father and I, who I joined his practice, Dr. Khan was saying, we needed a new YAG laser. We had an older laser. We finally needed a new one. So we went to a large meeting called the American Academy of Ophthalmology, and we went to this company called Alex at the time, and they had a new laser that they were rolling out that was a new type of laser that had a different, what we call optical system, a new visualization system that allowed us to do something called coaxial illumination. What that means is we can see with this type of laser all the way to the retina. Majority of the other YAG lasers that we use did not give us, even with special lenses, did not give us the ability to see further back behind the lens, so further all the way to the retina. So we couldn't identify a lot of floaters, and we couldn't see where the floater was in relation to the retina all the way back there. So spatial context. Number two, this laser that they were rolling out also had a different, what we call energy delivery system and a cooling cavity. So it allowed us to fire more shots and be more consistent. So safety was improved because sometimes the energy levels would not be as safe because it would overheat with other type of lasers historically. quickly. So this newer laser that was coming out in 2012 had a cooling cavity, and had a different illumination tower, as well as the delivery of energy was more truncated, more efficient, less scatter, or less shock wave as well. So because of those changes, they were like, hey, this is a great YAG laser, but what are your thoughts on this new procedure, Vitreolysis? What do you think? And no one else had done it in the United States. Really, there's a couple doctors who were doing it, Dr. Geller, Dr. Johnson, but not many other people were doing this as well. And there's no protocols. So I kind of started working with this company saying, let's develop a protocol. Let's develop some more studies, let's present studies, let's publish studies, so that way this becomes more standardized versus just people kind of guessing what to do. And so I kind of worked with them, and long story short, after years of working with them, doing procedures and really understanding the really delivery of energy and the safety of these YAG lasers, we started developing the protocol. And I started traveling around the world trying to teach doctors the ability to basically break apart and vaporize. And one of the key factors to the patients and the doctors out there is one thought. So if you have a Weiss ring, a clump in the vitreous, one of the perspectives or perceptions of a YAG laser is that you're just breaking up. Because for a YAG capsulotomy, for the cataract cloudy membrane, we really are just breaking it up. But with the vitreolysis, what our goals are is not just to break it up, but to also vaporize. And it's important to understand the laser energy in this YAG laser is something called plasma. It creates a plasma reaction. Plasma is solid to gaseous state, fourth state of matter. Long story short, we are vaporizing, but we're not vaporizing a lot at one time. We're vaporizing a very small amount. So you have to break and vaporize, break and vaporize. So there's more number of shots and higher energy we're using in a YAG vitreolysis than you do with a YAG capsulotomy. But from the perception of the patient, is no pain. It's all hollow inside the eye. And it still just takes a few minutes in the office as well. The key for us as providers and for eye doctors is to know exactly where we are in the vitreous. So one of the key differentiators from this laser and other lasers is the fact that we now can see all the way to the retina. So I can see, is a floater in focus and is the retina in focus? If the retina is in focus at all, or I see the vessels of the retina, I don't want to take a chance I'm too close. If the retina is out of focus and the retina or the vitreous opacity is in focus, then I feel safe. So spatial awareness, where's the lens capsule in the front part, and how do I make sure I don't hit the lens and cause a cataract if they're, let's say, had never had cataract surgery. So these little nuances are things that we started getting better at. We started developing protocols on how much energy to use, how to differentiate where you are front, and how do you use that coaxial illumination to see how far back you are. So that took a lot of time and energy and effort to teach doctors to get this kind of standardization, to present papers and publish papers on safety. And I'll just say one last thing real quick here. I could take forever. I'm sorry, guys. But
this is great.
It's really one key, I think, factor that a lot of eye doctors don't understand, I think, are scared. Because think about it from a perspective of any optometrist or ophthalmologist who does lasers right around the country will tell you that when you do a YAG capsulotomy, what happens? It goes, phew, it breaks up everything. You feel this big shockwave almost. You're like, whoa. So your thought is, God, if I fire that in the vitreous, I'm going to blow up the eye. Oh my God, right? I can't do that. But what we have to realize is the amount of energy, the shock wave, is called the convergence zone, right? That's the shock wave of that plasma. What happens when you fire a laser? There's an acoustic wave of energy that forms around that plasma. And then what happens, it causes a shield to prevent further propagation. So that way the energy comes back towards you. So even if you raise the energy and crank it up, right, the amount of increase in the shock wave is minimal. So for instance, for the geeky doctors out there, at 1 millijoule, which is very low, one of the lowest you can do for these lasers, it's about 110 microns, 0.1 millimeter shockwave. If you increase it to 10 millijoules, we go to about 5 or 6 millijoules, but if you increase it to 10 millijoules, so 10-time increase in energy, the increase in shockwave is only to about 220 microns, 0.2 millimeters. So that is really important, because when you hear about the data and you see videos of us lasering in the vitreous, you think, God, they must be causing a lot of inflammation and traction and, exposing the eye. But we don't see that. We have a lot of data on ultrasound energy and looking at how much is moving around the shock wave. It's so consistent and microscopic and really targeted in where we're actually doing the laser that we don't see pulling and traction. We talk about, why do you get a retinal detachment? From pulling and traction. Well, with the vitreolysis, we're severing, we're breaking the strands. We're not physically pulling at the strands, and the amount of energy that's propagating away from that plasma is so minimal. So from a safety, and we can go into detail, but we found with data that we presented at ASCRS and AAO and publications we published and other doctors around the world have published, we're not seeing an increased risk of a retinal detachment or retinal tear in these healthy individuals if you've already had a PVD. And I think we're seeing now also with something called ERG, which is testing of the the health of the function of the retina cells. We haven't seen any disruption to those functional cells after doing a number of shots as well. So I think to me, vitreolysis started with really this kind of amorphous kind of idea that was been done for years before I got involved, Dr. Geller and other people as well in Europe. But what we have with this new laser and developing a protocol, we try to standardize it. So we made it a procedure that many doctors could adopt and not have this kind of black box like, oh no, what do I do in this situation as well? And that was what I think changed the motion, what I kind of got involved, helping to train kind of our US doctors and some of the world doctors as well.
Well, all of that is amazing. Thank you for sharing those details, because I know, I think both, not just doctors, but I think just everybody who's listening in who has floaters and is maybe considering, what options do they have, I think people will love to hear this information. I know if I was going to have this procedure, because again, right now I do have floaters. I'm not as strongly nearsighted as you are, Jeff, but I'm up there. But if I was going to have the same procedure, like I'd probably want to know, like, what are the risks? What are like the chances, contraindications? Like, what kind of education do you normally give to the patients who are going to have this?
Yeah, no, that's a really good. Oh, go ahead, Jeff. Please, you go first.
I was going to say, just to kind of, piggyback off of what Paul did, when I first joined the practice with Paul and I was learning about this procedure, one of the first things I had him do was that procedure to me. So Paul has actually performed the vitreolysis procedure on me, and that helped my buy-in with the process, because there's always skepticism across the board, whether that be as a patient or, as a provider. And Paul's, telling me all this great information. I go, wow, that sounds incredible. Well, if I'm going to provide this as an option to my patient, to me, it has to be something that I'm willing to have performed on myself too. So I said, hey, Dr. Singh, I've got a ton of floaters, as we kind of mentioned earlier. Do you think you can, I'd be a good candidate for this? And he's like, let me show you how awesome this is, So and it's been a great experience for me too. So yeah, go ahead, Paul. You can talk about
that's I forgot about that. That's like one of my earlier ones too. That was like my first few years I started doing it. So thank you for trusting me. I forgot about that. So thank God you can still see. That's a good thing. But no, it's a good point. I appreciate you bringing that up about safety, because there's almost no procedure in eye care that has zero risk. So you have to be aware of that. So I want all my friends and patients to understand that. Now, the main risk that people think about is, well, if you're going on inside the eye with a laser, are you going to fire the vitreous, are you going to cause a retinal detachment? I can never say that you have zero chance of having a detachment, because a detachment can happen at any time, regardless of doing nothing. As you probably know from a lot of patients coming into our offices. So a retinal detachment can happen spontaneously, no matter what. Now, are we doing energy into the vitreous, and are we changing the chemical makeup of the jelly? Yes, technically. So technically, could you have an increased risk? Yes, theoretically. Practically, in the data we presented, we did not see that increased risk. So it's something that we always tell patients about, just to be fair. A tear, if we see a tear, which is what we do we want to dilate your eye about a month out, we look for a retinal tear. And if we see one, you could technically take care of that with a laser, usually, which is very safe in the office to seal it down, called retinopexy. But the other main things that I see once in a while that are still very, very rare, but still more common than a retinal tear, is something called a pressure spike. So the eye is like a water balloon. So the eye makes fluid to keep the shape of that eye. And there's a drain inside the eye where the fluid leaves the eye. You heard of something called glaucoma, where the pressures can go up in the eye. That can potentially cause the nerve in the back of the eye to become damaged. And so what we think is happening in laser vitreolysis in certain patients, if you do a lot of energy, especially in certain type of patients who, let's say, have already had a cataract surgery, already had a YAG capsulotomy, and the floaters are very cloud-like and more in front, right behind the lens. What we think is happening is those particles that we break up with the laser, we are breaking and we are vaporizing, but some of those particles are broken up. They may migrate in the front into the drain where the fluid leaves the eye, potentially cause a pressure spike. So I've seen very rarely, but once in a blue moon, and Jeff can probably attest to this, sometimes you can get a pressure spike. So we have to limit the number of shots and number of sessions just initially, because we want to double check that the pressure doesn't go up for those patients as well. So I limit that, and depending on the patient type and where the floaters are located as well. So that's one thing I've seen very rarely.
And I would agree.
Go ahead, please. Yeah, go ahead, Jeff. Go ahead.
But I was going to say, as somebody who's screening a lot of these patients as candidates for some of these procedures, if I see some of those floaters anterior like that, I'm thinking that, and I go, hey, I might not think you're a great candidate, but we'll still send to Dr. Singh and see what he thinks, and I'll make notes here about, what I'm seeing and a potential increased risk for concern there. And if he sees it too and he agrees with it and he doesn't feel comfortable, then, ultimately that's up to him to decide what's appropriate there. But that's something that us as optometrists, we can look at to say, hey, your risk for this isn't zero, but it's still a safe procedure overall.
Yeah, and if the pressure goes up, you can also put people on drops temporarily, and usually it comes down. And there's other ways to bring the pressure down if we had to, but it's something that I watch for. Second thing is you can hit the lens in the eye. So if you have a natural lens, you've never had cataract surgery, right? So your natural lens over time naturally becomes cloudy in a lot of patients, and 100% of patients over time, and that's called a cataract. Now, we can induce a cataract, we can cause a cataract if we hit the lens. So if you're not comfortable with the procedure, and part of the learning curve for us doctors and surgeons is really knowing how far away is a floater from the lens itself and how far can we fire and what's that safe distance. We say about a 2 millimeter safety zone, but that's a little bit hard for some doctors who are starting out. So long story short, you could technically hit a lens in a patient whose, let's say, natural lens is still there. So that's also something I look at. I look at how far is that floater from a natural lens. And if it's really, really close, I'm like, it's not worth it. I don't want to cause any problems, cause a cataract. Now, of course, we could fix it, but we don't want to have to do a cataract in a 30-year-old or 40-year-old or 50-year-old if we don't have to, especially if they're younger. But the last thing I would say is you can hit the retina. So, if the floaters are way, way, way back there, really close to the retina, I mentioned earlier, if the retina's in focus and the floater's also in focus, I've kind of learned to say, you know what? I want to be a hero. I love being a hero, but sometimes the best thing to tell a patient is not right now. And there's different tricks that we have, and I've learned how to move the lens and move the eye to move these floaters around to get them to a safe zone. But sometimes it is hard because, again, you can't hit the retina. Now, if you hit the retina in the periphery anywhere, we have not seen any reported cases of causing a retinal detachment or tear. If you hit the retina, just these small scar forms, but patients are asymptomatic, means there's no symptoms. But the one thing we don't want to hit is the optic nerve or the macula, the center of the eye, because that could cause some loss of vision. So we have to be careful knowing when to not fire and explain those to patients as well. So those are the main risks, I would say.
So let's say I came in, let's say I flew to you guys' clinic and I was really struggling with a floater and it's been over 6 months and it's just driving me crazy. Can you guys walk me through like the patient experience of what that would be like? I know, Jeff, you mentioned earlier that you usually go through a process of kind of somehow measuring their vision beyond just 20/20 on the chart. Can you kind of speak to all that?
So there's a device that we use in clinic called the eye trace, which is essentially a wavefront aberrometer that we use to really give us a quantitative vision of an assessment of how the optics is focusing throughout the eye, essentially. And Paul, feel free to jump in on anything with this too. But the way I look at this is I will have this test performed on the patient. We'll do a dilated exam, and I will see this test will show me, here, it gives me a number of reports, essentially. One column that says, here's the corneal data and how light is focusing just through the cornea. Another data of how the internal optics is presenting that image to the back of the eye, and that can include something like a cataract. We often use this with our cataract evaluations as well. But say the patient has already had cataract surgery, that tells me, there's not really much else left going on other than the vitreous there. And then there's another column that it combines all of those. So despite the patient, telling me that I've got this visually significant floater that's driving me nuts, I can get an actual measurement to show not only where it is in the vitreous, but how it's impacting the overall visual system and how much. And it gives us essentially on a scale of 0 to 10, 10 being perfect, there's no issues, and 0 being, light isn't entering through that eye really at all. It'll give us a reading somewhere along that, and it'll say, hey, to kind of show me this one is pretty low. This guy's got like a 3, or this patient's got a 4. And that can tell me, hey, this is somebody that's really being impacted by these vitreous opacities, and somebody that would be a good candidate for, a conversation with Dr. Singh about surgery there. Now, additionally, if you don't have that kind of equipment, if you're, a provider that just has like an OCT, for instance, if they're hovering, in that kind of posterior vitreous area, and you do a MAC OCT and that's hanging right above the retina, for instance, you'll see a large artifact. You'll see a large shadow kind of cast down on the retina and impact the quality of your scan. So you can really see, and we've shown this in studies that we've done, how once we've removed the floater, how much clearer that image has gotten. You can also just take a picture. You can take a fundus photo of the back of the eye and say, yeah, I see that, huge cobweb floating around there. I can see how that's affecting your vision and the location. So there are a number of things that I can do to, take quantitative measurement on that there with that exam and just really see how impactful that is for that patient's quality of life.
Yeah, to Jeff's point, I mean, I think this eye trace machine that we're talking about has really given us a lot more objective ways, objective data to really kind of help prove that these floaters are not just nuisances, that they can affect the quality of vision. So we think about something called contrast sensitivity. And so, for instance, you'd have these patients coming in After cataract surgery even, right? A beautiful cataract surgery, the surgeon did a great job. The patient still sees 20/20 on your chart, but they're coming in like, I'm not happy. Or after what we call a multifocal lens, even where they have rings in the lens for distance, computer working close up. And they're like, why, doc? I can't see. And we think it's a lens causing splitting of light. But we have this eye trace, and as Jeff was mentioning, it shines 256 lasers through your eye. And it looks at where the lasers are supposed to fall into the retina, but how do they actually fall? The size and the intensity of those little spots. So we can measure contrast, loss of quality of the optics of those lasers. And so we can separate the surface of the eye versus internal optics, as you mentioned. And so we have something called higher order aberrations. Think of it as like the more scatter of the light that as it goes to your eye, that higher that number is. And so we can actually quantify, to Jeff's point, and then if you have these cloud-like floaters in the middle of the vitreous, the middle of the center of your vision, we can see after laser or other procedures like a vitrectomy, where we remove the floaters, we can see significant reduction in that higher order aberrations or improvement in the curves for your contrast. And we've seen patients now who had those multifocal lenses, and after having these procedures done, can now read 1 line, 2 lines better on their chart, because they got the floaters taken care of. It wasn't the lens itself or the surgeon's fault. It was just their floaters as well. And so I think that's something that really helped us at least convince a lot of doctors who just felt, these patients are just complaining. They're fine. The floaters live with them. They're not really that big a deal. You're still 20/20. Why are you complaining? We finally know why, because the quality of vision, not just quantity, has gone down.
So after, let's say I came in and let's say I'm booked for the procedure, I'm going to go sit in your chair and you're going to be pulling this laser out on me. Can you walk me through, again, just like the patient experience? So I imagine they're going to have their eyes dilated and then I'm going to sit behind this laser. And
yeah.
What's the experience like? I know, Jeff, you can speak to it. You've had it done.
Well, Paul, you tell them what we're going to do, and I'll tell you what it feels like.
Okay, sounds good. You'll tell me the truth, right? No,
Yeah.
so part of that evaluation, I didn't remember to I make sure we didn't forget. So we do, besides that eye trace, that machine that does the lasers, we also dilate you, check your pressures, look at the retina. And I try my best to document where the floaters are located behind the lens. So I try to document where they are in relation so I can know where to look for them. And I'll also ask a patient to draw for me, because I think it's important. A lot of times you may see there's a disconnect between what the patient sees and what we as eye care providers see. So someone may have 15 floaters and dots, strings, clouds, this, that, but the patients that are having symptoms will always say that there's 1 or 2 big ones that I really remember and really are always obtrusive for me. And they'll draw it for you. They'll have a size, shape. They'll say it comes from here, comes from there. So that helps me then try to localize those floaters, especially when I'm doing the procedure. So once we're done with all that and we consent the patient, everyone's aware of what's going on, then we go back. The laser is really, really a very small laser. It looks like an exam room, like you get your slit lamp, like you're getting your eyes examined. It looks like one of those things. So it's not very scary looking at all. We put a drop to numb it up, a drop called Preparacaine, which is like a lidocaine for your teeth, like that, like Novocaine, but it's a drop form to relax your eye. And we put a little lens in front of your eye. That lens that keeps the eye open and allows us to see all the way. I have no financial interest at all in this, but I helped create a lens by a company called Volk called the Singh Mid-Vitreous lens. It's a lens we use to actually help view the retina as well as all the way front to the lens. So I have a good view of the whole entire vitreous. And then once I have that lens on the eye, I'm able to kind of take a few minutes to look around. It's a bright light. It's very bright. That's the one thing that patients do complain about, is how bright the light is. And we need that light to see all the different structures of the jelly and the retina. But once I get that on the eye, I'll sometimes move the eye left, right, up, and down, tell a patient to move around so I can see the floaters where they're located, give myself that kind of awareness of spatially what's going on. And once I see the floater, I want to do it, there's an aiming beam that aims onto the floaters that I can see. And remember, these lasers do not cut anything or fire, and it cannot hurt anything until both of the beams come together. That's why it can go through your tissues without actually kind of hurting your tissues. Once we see it, we fire, we go click, 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 and it feels like a little click sound, or you hear a click sound, like a snapping sound, and you'll see you've got kind of bubbles floating around in your vision sometimes as a patient. And we just keep doing that, break, click, 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 click for about 5-10 minutes or so, and I'll have the patient look up and down, left and right. And after that, pretty much take the shield out of the eye, the contact lens out of the eye, and you can go back to daily activities, 0 restrictions. There's no risk of infections. You can go back. You can fly the same night if you want to, go play basketball the next day. There's no restrictions at all. So that's pretty much how quick and how straightforward it is. Jeff, is that pretty close?
Yeah, I mean, the worst part of it's being dilated. Just like, a routine eye exam, you go home and you want to see the improvement immediately and you got to wait for the dilation to wear off. But in terms of, the comfort, it wasn't uncomfortable at all. There was no pain or discomfort, I would say. Maybe a little awkward just from having that contact lens on the eye if you've never had that before, a little pressure sensation, but nothing, painful or unbearable or anything like that. Yes, I did hear the clicking sounds. I don't know if I felt like this is kind of an afterthought at this point, but maybe a little vibration. That's about it. I didn't notice any bubbles or anything like that. And then, I remember following up with you, and we were just talking about the percentage of improvement that we had in the floaters that we were treating for me. And I think it was something like 70%. It wasn't, in this case, it wasn't completely gone because I had a lot that needed to be worked on there. And sometimes the reality is we just can't get them all done in one treatment. Sometimes it takes multiple sessions to remove those visually significant floaters. But, a significant improvement, I would say, overall. And yeah, that was it. There's no drops, there's no medications, there's no restrictions, nothing like that. It's just being dilated. It's really the worst of it.
And then probably follow up maybe like a month later or so just to make sure everything's good, right?
Yeah, typically 2 to 4 weeks.
2 to 4 weeks. Great.
Yeah.
So I know just for sake of time, I think this has been great. This is also fantastic information. I think people are going to really get a lot out of this. But I know you've mentioned that there's kind of this, newer procedure, or you've got some new developments coming up. Can you speak to like kind of what's on the horizon or what's coming out at this point in terms of like any advancements?
Yeah, absolutely. So I love the laser. I think the laser works beautifully, and we have data we presented and published on Weiss rings and those solitary opacities. They work very well. In fact, today I did about 3 patients who had that Weiss ring, and it's wonderful for me as a surgeon because you see it vaporize and break up, and you're awesome. The problem is when you have strings and clouds everywhere. The problem with the laser, remember, it doesn't have a lot of vaporization at one time. Every time we go click, 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 it's not like we're blowing up the eye. It's, like I said, very microscopic in how much it can vaporize. So you sit there, go click, 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 click. If you do like 500-600 shots, what we talked about earlier is if we do too many shots, the pressure can go up. So we kind of limit the number of shots, and then we say come back and for a follow-up in a month. And a lot of patients will come back and say, Doc, I'm 20% better, 30% better, 70% better. And for some patients who have a lot of strings and everywhere, it's just still like, Doc, it's not much better. We do a second session, do a third session. They're like, Doc, I'm like 10% better, but it's just taking forever. And so because of that, we want to do something called a vitrectomy. And so there's a lot of my retina colleagues out there who are wonderful. They're doing very efficient, quick, full, what we call pars plana vitrectomies, where you put these little special little trocars, little openings into the eye. They can just really beautifully remove the entire vitreous gel. And that's wonderful. And I think it's a great procedure. But for someone like me, who's what we call an anterior segment surgeon, we don't do a lot of those vitrectomies. There's a newer technology that just came out about a couple of years ago. And we actually presented this data at ASCRS, which is the American Society of Cataract Refractive Surgery. We won best paper session. And what this was is basically, well, thank you. And what this was, we did actually 70 patients who actually had this one-step limited vitreous removal. So what does that mean? This came, instead of putting multiple trocars and openings into the eye, we have one microscopic opening. Like when someone has macular degeneration, they get those medicines into the eye for macular degeneration, like that size. So very quick and straightforward. And we use that and another small portion to keep the chamber formed. It's called an AC maintainer. That's it. So we go in there and we do a partial or a limited vitreous removal. Now, what does that mean? So instead of removing the entire jelly, we say, okay, let's go in there with very, 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 very low vacuum and remove it. It has a microscopic, at the tip of that little microscopic probe, has a microscopic little cutter, goes back and forth, and that removes the jelly. Remember, there's no pain fibers in the eye. It's painless. We do it in the office. And what happens is we use a very low vacuum, and all we're doing is removing whatever liquefied vitreous is there. So in other words, the jelly we talked about, right, is changing and becoming liquefied and clumping together. Well, what we don't want to do is disrupt the vitreous that's attached to the retina. Right? We want to leave that alone. Just take care of whatever vitreous is floating around, whatever clumps are floating around. So if we use very low vacuum and we use a small microscopic probe, we can get those small pieces, whatever is floating around, come to the tip and not disrupt the entire vitreous that's attached to the retina. Because the biggest fear people have with the vitrectomy is inducing what we call a retinal tear detachment. So we pick patients who are post-cataract surgery, who've already had, let's say, a PVD, that vitreous that's detached already. And so using very low vacuum, we have found in this study, we had no retinal defects in the study we did. And we found very high satisfaction, 90+% satisfaction. And we found that 100% of patients were back to baseline vision at 1 week. And so quick recovery, very high satisfaction, very comfortable in the office. And we did not see retinal detachment issues, which is why we were so comfortable, because we're using very low vacuum. So I don't say jump to that for every patient, but I would say for those who, let's say, have a lot of strings and clouds everywhere, they tried a laser session once or twice, it didn't do much. This now has allowed us to say, don't worry, we have this other opportunity. And if worse comes to worse, we needed to take out more of the jelly, we can send it to our retina colleagues to do a full, what we call pars plana vitrectomy. But this is called one-step limited vitreous removal. It takes 5-10 minutes right in the office. And I think Jeff could tell you, because he sees all my post-operative visits for the most part, him and my other optometric colleagues. Jeff, you want to talk about what you see, I guess, post-operatively?
Yeah, I mean, in terms of results for these patients, it's really been incredible, life-changing for this, like we were expecting, and that we do get in many instances with the vitreolysis. But, Paul can tell you, I'm not a very patient person. And when I've got, patients that I've become friends with because they've had multiple rounds of treatment, it's like, okay, I already know what the spiel is going to be. I know it's improved, but it's, I still want more. It's not improved. When are you going to get this floater away from, or these floaters out of here for me, doc? So having this as an option in the lineup now can give us immediate satisfaction at a very safe and efficacious way. And the patients that, the real wow factor for me that really kind of bought me in on this was the ones that we were doing the vitreolysis multiple times, and it's been great. But we turn around and we do this, and they're like, I don't see a thing in terms of floaters. I don't see any floaters. They still see very well,
Yeah, they can still see, I promise.
yeah. But they don't see any floaters anymore. And I'm like, are you sure? Because I know you like to, still tell me what you still see. And so I go in there and I double check, and I had to, ask Paul, especially after the first few ones that we're doing, I'm like, dude, was I looking at the vitreous? Like, I don't see anything in here at all. And what are we doing? What's going on? And all that. And it's just been incredible, because I'm used to seeing, just all this kind of snow globe like stuff that was there pre-op. And then now it's gone post-operatively. And the patients are just beyond happy with the results. I haven't had anybody complain about discomfort or pain. We haven't had any complications post-operatively there. We will have to put the patient on a regimen, an antibiotic and a steroid, just to make sure inflammation is handled appropriately, but that's very minimal to begin with. So it's very easy in terms of my job. Most of my job with vitreolysis is just having a conversation with the patient about expectations and how many more times this might potentially take. This is problem solved. You cured my issue in this case, one and done, and it was nice to know you. I'll see you next time if I need, kind of deal. So it's been great for the patients. It's been great for us as clinicians in terms of what to expect and what to manage post-operatively. So I love it when he does it, because I know we're going to have a very happy patient right afterwards, and I'm going to be very happy because it's going to be pretty easy on me at the end of the day. So
I love that. I know, just thinking about it, I need to find your paper. I need to read it. I need to better understand this myself, because that's just the type of doctor I am. But I know another question, anybody who's listening in probably is thinking, this might be something, this might be really good either for yourself or for family or somebody but people always want to know, how much does this cost, right? Because, and you maybe can't speak to every clinic, because every clinic may set their prices. But from what I understand, at this time, there's no insurance coverage for these types of procedures. But do you guys have an idea of range of what somebody might end up being charged if they need this type of laser vitreolysis, for example?
Yeah, no, it's a good question. So without getting too detailed, because it has to do with insurance and how we code it, for a Weiss ring type of floater, because we're trying to vaporize, the way some consulting firms have kind of given us their recommendation, because we actually asked them first, what is appropriate for Medicare especially, et cetera. And they said, look, if you're trying to vaporize these floaters, it's not covered under, there's a certain code called Vitreolysis code. And so if you're trying to vaporize, it's not in that code, we charge around $600. So it's not thousands and thousands of dollars. So it's not crazy expensive, but it's about $600 for each session. And then we do, if it requires multiple sessions, we tend to go lower for the second and third sessions. If we are trying to break the floater, let's say you have a large strand and we're trying to sever it and move it out of the center of the vision, that we can sometimes get insurance to cover. So that's why it's not always 100% yes or no, depending on the type of floater, where it's located, what we're trying to do with it, if we're trying to vaporize it or just break it up and sever it, we call it. That severing there's a code for that from Medicare. And so we can actually bill for that if that's our main goal for that patient. So that's why I would say it just depends on the type of floater. We have to wait and see when you come into our office, but around $600 for the Vitreolysis if it is cash.
Perfect. Thanks for just commenting on that, because I know the price is sometimes a tough thing to discuss for some different medical procedures, and insurance is a whole game. I think everybody's frustrated and doesn't fully understand. So just thanks for commenting on that. I know we covered a lot of different stuff here, and who knows what's kind of on the future. I imagine you guys are still going to be kind of tinkering with ideas and maybe...
Yeah, I was just gonna say, sorry to cut you off. Sorry, Doc. But no, there's a lot of cool technology. Just I want everyone out there to realize that I think people now in the community of ophthalmology and optometry are really starting to respect the impact that floaters have on daily life. And now there's a couple companies coming called Pulse Medica and other companies working on lasers that are going to be more automated and track these floaters and use femtosecond lasers and excimer lasers and different lasers that can, besides the YAG laser, that can actually break these floaters up. So that way, some surgeons who, let's say, aren't as comfortable like I am in the Vitreous and using it manually and figuring things out, can have this automated OCT guided kind of measurement that can allow us to treat these patients with more an automated type of appearance. So I think we're going to see a lot more technologies on the laser front, diagnostics, being able to kind of document and really identify these floaters automatically as well. So you're going to see a lot more technology in the next 5-10 years. Sorry.
Well, no, that's kind of where I was gonna kind of go to. But I know as this technology comes out and we have more options available, I'm sure we'll invite you guys back on to speak a little bit more of what's happening. If somebody is hearing this and they're like, okay, these guys know what they're talking about, I want to go contact them, what's the best way they can reach out to you?
Yeah, no, thank you for that. Please reach out to us. So you can go to our website, first of all, just to get some more information on who we are. We are the Eye Centers of Racine, Racine, and Kenosha. So the Eye Centers of Racine and Kenosha. And our website is www.amazing, so AMAZING, EYE, www.amazingeye.com. And then in that, you can scroll down and see our locations, and our phone numbers are out there as well. And then you can also reach out. There's a little icon to information. Just you can email us if you have questions. There's a little submission form, and you can make an appointment online too as well. But we do take patients from around the world. In fact, I had a patient who came in from Brazil, one from London just recently, from around the country. Because although this is something that a lot of doctors are doing around the country and the world, there's still a lot of doctors who are fearful of this procedure because it's the unknown, and it just takes a little bit more time to kind of feel comfortable and learn it. So we do get a lot of doctors who've sent me patients, and we send them right back. So please feel free to reach out, and we'd love to help you if we can. Absolutely.
Thank you for just sharing that. And the final question I have for you guys tonight, and I've got a few of them that I like to ask doctors, but clearly you guys are really passionate about what you do as being eye care professionals, and certainly like researchers, inventors, you guys are doing a lot. But if it wasn't eye care, what other profession, what would you be doing?
Well, I think Paul's got the answer right behind him. Yeah.
Yeah, this is my music studio, basically. I'm in a band actually called Funkadesi, Funkadesi. We opened up for Prince, Shaka Khan, Los Lobos, some pretty cool places. But yeah, and I really, what I love so much about this band, I feel lucky to be part of this band because it's a eclectic group of 12 musicians now that are really focused on equality and diversity and really teaching kind of inclusion through the music. And our famous phrase is "one family, many children." And we mix styles from India, Africa, Jamaica, Puerto Rico. And so for me, music is just a great way to connect with people, to find the commonality. There's so much more that binds us than separates us in this world. And I think if you can focus on more of that, and a 4/4 rhythm in India is the same as a 4/4 rhythm in Jamaica or New Orleans. It's a 4/4 rhythm. And that's the idea behind the band. So music is something I'd love to do if I could more often. No doubt.
I love that. I'm going to have to look up, I'm going to have to get connected with that band, and that's probably going to be jamming out to for the next few weeks.
Go for it.
Yeah, for me, I mean, I'm kind of a jack of all trades. I got a number of things. I'm a very inquisitive person. I like to get myself in trouble with a number of things. But, kind of to Paul's point, in terms of passion, I would really say one of the passions that resonated with me and stuck with me, my entire life is cooking. I love to cook. I love to spend, if I'm not working or doing something with the family, I'm probably in my kitchen tinkering with something because, just like Paul was saying, music is another form of language. Food is too. It's a way for us to connect, and talk and bond. And some of our fondest memories are over meals or, taste, just like smell can really stick with you. So I spend a lot of time. I also, just love the science behind it. It's really, we went to school with biology and medicine and all that, but where I really found, besides for my daily activities of application of that, is just kind of the science of food. I love it. I love watching how it can change. So I spend a lot of time cooking myself.
Wow. Love that so much. Thank you guys. Again, just incredibly grateful for you spending some time and sharing your knowledge with us. And I hope that, we'll probably have you guys on again in the future. So thank you.
Yeah, thanks for having us.
Thank you, Joe. Appreciate that. This was awesome. A lot of fun. Thank you for the opportunity.
Spend a lot of time cooking myself.
Wow. Love that so much. Thank you guys. Again, just incredibly grateful for you spending some time and sharing your knowledge with us. And I hope that, we'll probably have you guys on again in the future. So thank you.
Yeah, thanks for having us.
Thank you, Joe. Appreciate that. This was awesome. A lot of fun. Thank you for the opportunity.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.